fast. I'll just share 3 videos which will essentially to a comprehensive ophthalmologist point out the basic techniques. Can the size be a little shorter? It's become a little too large. Missing out on parts. And we need to look at the basic principles and look at the techniques either for non-marginal defects or full thickness defects, and particularly on how to construct our canthi, lateral and medial, in order to get the right position of the eyelid. So various types of unilateral or bilateral upper lid colobomas may be present, but the most common reason why we do a repair is for surgical resection of eyelid tumors followed by trauma. So we need always to consider the eyelid as being constituted by anterior lamina constituted by skin and orbicularis, and the posterior lamina constituted by tarsoconjunctiva along with levator and Muller's muscle. And we need to reconstruct both, preferably at least one with a retained vascular supply, either as a flap or some other way in which we can retain the vascular supply, like for example a vascular pedicle. Now, the non-marginal defects are usually converted into a simple elliptical shape, preferably along lines of tension, so as to avoid creating any pull by the fibers of the muscle, Langerhans line that we used to know about. Some of these defects like this can be taken care of by a partial thickness skin graft. But most often we require to do full thickness repairs for defects like this. Up to 1/4 defects can be direct closed, like in this case. So let's look at the video for repair. So this is a technique which uses double vertical mattress sutures, 3 vertical mattress sutures, work under magnification and good illumination, preferably microscope or a loop. First suture, as you see, is a vertical mattress suture which went 3 millimeters from cut edge and came back to the same side 1 millimeter from the cut edge, 1 millimeter depth. And when tied, it gives a little pout. The first suture was just posterior to the gray line, which is giving a firm bite through the tarsus. Second suture, as you can see, is closer to posterior margin. And again, as a vertical mattress suture, we are using a 6-0 silk. And once these are tied, they are giving a good pout. The third suture is close to lash line and is then again coming back in the same way, and you can see that the posterior 2 sutures have been left long so that they can all be tied in the anterior most suture. Silk is softer, so less chances of causing irritation to the globe, and the posterior sutures are tied in the anterior most sutures so that you do not have any suture ends going posteriorly. Now partial thickness bite through the tarsus with 6-0 vicryl so that you close the tarsus well, and then after you've taken care of dog ear, suture the skin with 6-0 nylon or silk, whatever you prefer. So this gives a good marginal repair, and the face tissue being very vascular, you get very good results. So this is an example of a basal cell carcinoma excised as a pentagon. When the defect is a little larger, you need to use either skin flaps or a Tenzel's flap, where we rotate a flap from the lateral side of the canthus, or you can share the material from the other lid, either just the conjunctiva or both the layers. Now we will go, if you can see the video, I'll go ahead with the video. So this is the Tenzel's technique, which can be used frequently, and a comprehensive ophthalmologist can do it. We are making the edges raw, and then we will mobilize a flap on the lateral side. The defect must be made pentagonal with margins perpendicular to the margin, going up to the upper border of tarsus and then creating the pentagon. So you can see the flap that is being raised for the upper lid. It goes with a curvature down and goes up to the lateral orbital rim. Canthotomy is done, and cantholysis, which means the canthal tendon is also cut, and so that the whole flap is freed totally and is a running continuity with the eyelid margin, so that it can become a part of the lateral eyelid margin. See the lateral canthal tendon being cut, so that is cantholysis. and then a marginal repair is carried out as we discussed earlier, and that lateral part of the skin becomes a part of our margin. And then the lateral canthus is reconstituted, closed, and then the skin is closed. So that completes the closure. So Tenzel's repair can give you very rewarding results, as in this case of trauma, and it can give a correction which is quite good. You can use flaps from forehead or from the upper lid, which can be used for reconstruction. I'll just go to the third video. Now, about the lid sharing techniques are good because they take tissue which is very similar to what is needed from the other lid, and it is to be avoided in young children where tissue laxity is less and where you want to avoid closure of the pupil. So let's just look at the use of tarsoconjunctival flap technique, and then I'll just summarize. So this is a defect here in the upper lid after excision of a large meibomian carcinoma. So let's look at the technique here, how we use the inner layer, excising the tumor with a clear margin of about 5 millimeters, as you would do in a sebaceous carcinoma. And then the important thing will be that you must send it for histopathology, but before that a frozen section, especially in sebaceous carcinoma. So after sebaceous carcinoma, we get a report saying that there is an involvement on one aspect, so we do some more excision till we get a free report. And then a tarsoconjunctival flap is made just like any other flap in shearing the lids, with a 4 millimeter margin to retain the vascular supply in the fragment that is left behind. And then this flap is mobilized and used to create the posterior lamina. You can see how it is sutured. Both ends are sutured first, then the center is sutured, and then you can close the lamina. So this way you can get a good correction. Cutler beard procedure you utilize after the excision, the flaps, both skin muscle and tarsoconjunctiva from the opposite side. So if it is even larger defects, then you use inner lamina reconstruction by tarsoconjunctiva or nasal mucocartilage, and then flaps either from the temporal side or from the midline, as you see here. But lastly, we'll talk about the repair of the canthi. What is important is to anchor the tarsal plate to the lateral periosteum well, like we are doing here. Useful to use a permanent suture and take a double arm bite which goes from the periorbita, which means behind, the bite is starting behind the rim and then coming anteriorly and a little higher to give you good anchorage. So good anchorage for lateral canthus is important. And medial canthus, it is important to fix posterior to the sac at the posterior lacrimal crest to give the right direction. That is the key to repair of posterior medial canthus. So these are essentially, and then some cases you need low profile mini plates in order to get a good fixation. To conclude, eyelid repair is customized based on the properties of the defect that you have. Partial thickness defects repaired by simple closure. Full thickness defects, you need to reconstitute skin muscle and a mucosal lining with a supporting structure, particularly when larger. For smaller ones, just mucosal lining will do. And precise reconstruction and of lateral and medial canthus is integral. So a combination of techniques is important with sound knowledge and adherence to basic principles. Thank you.